All right. So I think ocular ultrasound is something that we use a lot because it gives us a lot of information and is a fairly straightforward exam. This is some of the straightforward stuff that we've already done, but then some more of the newer uses that I've been playing with a little bit, or at least just considering as things to add to our arsenal of eye ultrasound. I think the time we probably use it the most is with vision loss, especially painless vision loss, but it also has utility in headache. When I think about its use in trauma, which we'll get into, I think about it more in terms of places that are maybe critical access or uh, don't have access to 24/7 CT scan, or in unstable patients that it's difficult to get them to the scanner and back. Um, and we'll get into some of that too. And beyond the vision loss and the headache, there's also lots of interesting other forms of trauma that we can evaluate. So I think we have a basic idea of how to do it, but there is some controversy that's been brewing in the world of academic emergency medicine on, do we use it with the tegaderm or without? And I also include this just to show that there's lots of things that you can study when you're considering what your research projects can be, since there was recently published in American Journal of Emergency Medicine a randomized control trial looking at covered versus uncovered, whether or not the tegaderm leads to poor quality of your ultrasound images. And I think we all have had that experience where you don't have the tegaderm well flush to the eyelid and air gets underneath the tegaderm, and then you get reduced image quality. There's really no difference in patient discomfort with or without the tegaderm. I'm still on team tegaderm. Are you still on team tegaderm?
Oh yeah, it's such an easier cleanup.
Yeah, it's easier cleanup. Um, it's like you don't end up having there being residual ultrasound gel around somebody's eye.
Yeah.
Reminder that you want to get both the sagittal and in the transverse plane, and that you can improve your views by having your patient look up or down or left or right, especially if you're in the sagittal plane, having them look up and down, and then left and right if you're in the transverse will help improve your views, especially when you're trying to find the optic nerve and the optic disc. And just a reminder that this is especially important to have a stabilizing force of your pinky finger or your hypothenar eminence, just because not only is there the risk of sliding off of your midline in a patient that could potentially have trauma that you're evaluating, you want to make sure that you have really good control of the pressure. And this one is labeled as it should be, because if you're just looking at an image, it's just a round ball in the middle of some flesh. So just our reminder for what we are looking at here is obviously the transducer is going to be placed on the skin, and then you're going to be looking from the near field to the far field at the different bits of architecture that comprise the eye. So you have your cornea, your anterior chamber, and then you're looking at your iris and your ciliary body. Let me just get my laser pointer here. Your lens, and when you're looking up here in the iris and ciliary body, you'll be able to kind of see how the eye moves in terms of pupillary response. You got your posterior chamber here, and then in a patient that doesn't have any detachments, you have this nice, slightly more hypoechoic layer that comprises the retina and the choroid slash sclera. And again, this is just a reminder of those different structures when you're looking at the eye. The first thing, and probably the most common thing we use this study for, is for painless vision loss, which is pretty extensive differential. I won't torture you with it, but I think we're using it a lot for retinal and vitreous detachment, but just to kind of keep our minds open to the other causes of your central retinal artery and venous occlusions, your open angle glaucomas, you can have a stroke that's within the distribution of the optic nerve, And then if it's painful, there's less things, but always just keeping your mind open to temporal arteritis, optic neuritis, and just ischemic optic neuropathies. And I like to do this because it's fun. Do you see anything in this fundoscopic exam? This is absolutely
the
just
cherry
torture.
red? Just the cherry red
No,
photo?
actually.
No? Oh, man, I
I
was gonna
just
say it
do
looked
this, and
like
every once in a while, there's somebody that's done an actual ophthalmoscope exam in the last 10 years, which I don't think will be anybody on this call right now. Uh, when I did this for the residents, we did have one resident who correctly identified these, and it was very surprising. But this is just your crinkling of the retinal tissue over here. And again, this is just because I enjoy torturing people. But since this is an ultrasound lecture, what do we see on this ultrasound? Easy one.
It's like a retinal detachment.
Mm-hmm. Yep, and just our reminder for what this patient will come in with their, where they might have floaters, they might have flashes of light in lieu of having complete vision loss. That vision loss, if they have it, can be along a whole spectrum of just, I kind of think of it very physically, of how much of the retina is actually peeled away will impact how much of their visual field is lost as well. So on ultrasound, you get that hyperechoic line and that it's tethered to the optic nerve. And so then do you use the concept of MAC on and MAC off?
Yeah.
So
Yeah, as far as temporally, if it's detached on the temporal side or not. If it's detached on the
Exactly,
temporal
yep.
side, it's MAC off.
Yeah, and then the idea being that if it's MAC on, that there's still some salvageable material, and that it hasn't completely crossed over the macula, so there's still preservation of central vision. And just a schematic to further show that, and just that idea of it being temporal versus being more proximal or being more central. I'm not going to torture you with this. This is just more crinkling of retinal tissue. But here we get to the ultrasound. And then what are we seeing here?
This looks like a vitreous detachment.
Mm-hmm. Yep, and what makes it vitreous?
I can see the hyperechoic line, like starting on like the lateral aspect of the eye, and it extends to like the other aspect. I don't know if that's medial or not, but it doesn't look like it actually goes towards the optic nerve.
Yeah, correct. So basically everything that we said for the retinal detachment, except that it's not tethered to the optic nerve. So you see here, same thing, that hyperechoic linear structure, and it's not contiguous with the optic nerve. And to always remember that one of the large causes of a retinal detachment is a vitreous detachment. So they all kind of exist on a spectrum of horror. You can also see too, I've seen the description of this as like a sea kelp sign, which it actually kind of does look like beautiful sea kelp just floating. We can just stay on the screen for the rest of the lecture just because it's so relaxing.
It's very soothing.
This one's a glitchy form of what we were just looking at. All right, so then we move on to the kind of within that wheelhouse of things that can go wrong with your vitreous and your retina. Hazard a guess of what this is?
Hemorrhage, vitreous hemorrhage.
Yep. Yep. And again, like they always say that this is the washing machine sign, but just remember it has to be a front-loading washer machine. And again, very similar symptoms. Sign? Yeah, the top-loading washer machine sign. You don't see anything, honestly. It just shakes and rumbles.
Was that first eye the one that was glitching? Just shaking.
Yeah, that's the front. That's actually the top loading washer machine.
Gotcha.
So with vitreous hemorrhage, these are all very similar in their symptomology and their causes. But they can get also just this more of this haze that's just from that detritus of the clotting blood within the posterior chamber. I had wished that I meant to add an image from a couple days ago. Remind me and I'll put it up or I'll send it to you, from a patient who had prior vitreous hemorrhage and clot removal, but that was unsuccessful like 2 years ago. So the entirety of his posterior chamber is just thick hyperechoic clot. Like forever, like doesn't really even move.
I'll keep it as well, since it's being recorded, just say you signed this patient out to me and showed me the images.
Oh yeah.
And I went back, by the way, and tagged it on Butterfly. So it's tagged as vitreous hemorrhage on Butterfly.
Good. Yeah, and I favorited it too because I was going to add it to this. But when it hasn't been 2 years of clot that's been sitting there, it's swirling, it swirls. It's usually a little bit hyperechoic. And you can kind of see there that it kind of clearly moves as the eyeball moves. There's tons of studies that seem very variable on sensitivity and specificity. And when I do the deep dive into that, it seems that a lot of it's probably just related to ability to acquire the images. So if you're ever having trouble seeing those faint hyperechoic lines or that faint hyperechoic debris, you can always just like crank your gain up. There's really like very little harm in cranking your gain with the ocular exam, since otherwise, if there's nothing wrong, it's just a black void that will remain black even as you overgain it. So those are just our retinal vitreous detachments and vitreous hemorrhage. And then what are we seeing in this particular image?
Looks like
what are all?
Actually, I want to say trifecta, because it looks like you have a retinal detachment down there, vitreous detachment across, and then the hemorrhage right on top.
Exactly. So that person's having a rough day. All right. This is just some more gratuitous torture. Yeah, what's this one?
This is central retinal artery occlusion.
Artery occlusion. See, some things stay with us long after medical school. So now we're getting into some of the painless causes of vision loss that I hadn't historically used ultrasound for, but that you can have secondary indicators in addition to sometimes actually being able to visualize the clot. So just that reminder that it is a branch of the ophthalmic artery, and that it kind of travels with the optic nerve to supply the retina. So occlusion of it is an emergency because you actually still have a little bit of blood supply from the posterior ciliary artery, but it's not enough to supply the retina's need. So these are patients that will get their obviously emergent ophthalmology consult, and then you may even consider transferring for hyperbaric oxygen. And just to have this in the back of your mind when somebody comes in and they have kind of those vasculopath or those coronary artery disease patients that have a high plaque burden, diabetics, hypertensive people, people with cardiovascular disease. And what do we actually see on ultrasound? Sometimes you can actually see the clot. And it makes sense that you would also have unilateral edema of that optic nerve. And then the Doppler gets a little bit complex because sometimes it will just be absent, like you won't see any flow in the central retinal artery. But because there's still the posterior ciliary artery, even if the central retinal artery is occluded, you still may see some flow, but that it would be diminished as compared to the other side. So you can see where there's like good flow and then maybe less flow. This I feel like is a little more of a subtle finding, but obviously if you see a clot, if you have somebody you have a high suspicion for this and they have a unilateral edematous optic nerve, those would be considerations that you might actually be looking at a central retinal artery occlusion. So those are kind of the main painless vision loss uses that we have for point of care ultrasound. And now we're talking about headache. We get a lot of patients that have headaches that have either like not the most acute stories, or sometimes they do have acute presentations and we're having trouble finding out what the etiology of their complaints are. So this is a time where we can kind of look at a proxy for intracranial pressure. And this is basically, we're just looking at the diameter of the optic nerve sheath. And we're doing that because the optic nerve sheath is actually derived from the meninges. So it's kind of like a small compartment of CSF that's contiguous with the subarachnoid space. So as that pressure increases within the subarachnoid space, so does the optic nerve sheath diameter. So when we're measuring this, it's just really the key is that we've agreed on a set place that we measure it so that we're getting observable sizes that we can apply across different operators. So we're basically going from the line of from the optic nerve or from the optic disc, or if it's flush from the scleroretinal layer, going back 3 millimeters and then measuring across to make sure that we're including the optic nerve sheath. And that's just very easy to remember because it's 3 by 5. This is the fellows lecture, so it's going to be a little more advanced than that. So I'm sure you're already aware of that. That's how we measure optic nerve sheath diameter. But understandably, there's going to be some distinctions for different age groups. I think I haven't memorized these, but if I was to do this study on a younger patient, you could always look up the differences in expected optic nerve sheath diameters based on age. That obviously when you're a little tiny peanut, you're going to have a smaller size than when you're a full-fledged adult. And we'll get into the basics of that. Anything under 5 is considered normal, anything over 6 millimeters is considered abnormal, and then the 5 to 6 is kind of that in-between zone. The next step for this, I think we're going to see, even though there's maybe I've only found a few papers indicative of this, is that your optic nerve sheath diameter may actually be affected by how big of a person you are, which kind of makes sense, like in this intuitive way that I hadn't fully explored. But like my brain thought that there would be different sizes of optic nerve sheath. If you're a 7-foot tall, 350-pound person than if you're 5 foot tall and 120 pounds. And that actually seems like, or if you have a really big head or a small head. And there's been a couple of studies that I was able to find that are looking at a ratio of the optic nerve sheath diameter as compared to the eyeball transverse diameter, and using that ratio to address the fact that these numbers might actually be affected by other physical characteristics. So there's not like a general consensus yet on how to use this, but in a couple of these studies, they would show that that there was like differences within healthy and TBI groups that were more sensitive and more accurate if you included the diameter of the eyeball. And then just that reminder that under 5, if you're not using this ratio, is normal, over 6 is abnormal, and in between, then you're going to want to look at the next thing that we're going to be evaluating. Which, do you want to take another guess?
It's papilledema.
Yeah, papilledema.
I just want to point out, it's not actually the fundoscopic view that I understand. I just understand the flow of how to do the
but you know what?
ultrasound.
I was absolutely giving that to you, and I honestly was like, wait a second, I think that this was cotton wool spots that we were looking at, but I didn't want to draw attention to that. I barely remember making these slides.
Yeah, I was going to say it looks like that. Maybe the blood and thunder, but I don't know.
No, this is obviously cotton wool spots. I think we all can agree that we would 100% recognize that on any of our ophthalmoscope exams that we pursue within the emergency department. So for the ultrasound side, which we could argue for hours, I'm sure, on if this is easier than trying to do a fundoscopic exam or finding our fundoscope, would be for me, like, these are very small numbers that we're using. So I kind of just like, my brain just says, is there a bump, or as I sometimes call a nubbin, or is the optic disc flush with the scleroretinal layer? I think that if you're really seeing it, that's usually abnormal. Like when you look at a bunch of these eyes, you're not really even like seeing anything where the optic disc is. But if you are to measure it, you'd measure it from the retina to the top of the disc, and anything that's greater than 0.6 millimeters is abnormal. But again, those are really small numbers to be measuring. So I'm really like looking to see if I see anything at all. So you see like these like ones we were looking at historically, it's just very flush. Whereas in these, which are all patients that have papilledema, you can clearly see the optic disc, or the optic disc nubbin, as I like to call it, which if you were to measure it, my guess is that just looking at it is that it would be greater than 0.6 millimeters, but those are just very small numbers that we're working in. And as you can see there, like you're actually seeing the optic disc. So, this is just the kind of pathway that you can use, especially if you're not using eyeball transverse diameter, of in that in between gray zone of, do they have ultrasonographic papilledema? No, then it's probably normal. Yes, it's probably elevated. Are there limitations to this? There are. I was reading one study of patients who had either like high 5s or low 6s, and then went on to have full workups, and many of them still ended up having normal ICP after they had LPs, after they had diagnostic LPs with opening pressures and had MRIs. But again, in terms of the rule out structure that we're using, I think that there is some utility. Another place that I've seen it discussed and used, or at least and that I've thought about the best way to increase the utility of this, is with serial exams. Like if you have a patient that they come in, because if you think about in like a trauma, if they come in and they just got bonked on the head, it takes a while for ICP to start raising. So you will have, normal findings. In addition, it takes time for that increased ICP to translate along the distance of the optic nerve sheath. So there's still some time that would require for it to be reflected in your ultrasound exam. That said, let's say you're working in a critical access hospital. They have a CT head, they have some injury, they were polytrauma and you intubated them, but there's some delays in getting them transported. If you're doing these serial exams, you may just have another piece of information to call back your transfer center to try to expedite their movement to the tertiary center. Also, in some places where you don't have any access to CT scan and you're working on getting a transfer, then you can also look at that serial measurements. And seriously resource poor settings, I'm sure I've told Nick, but like I know of people who in conflict areas are using this to help guide their triage of who they're going to work on extricating from field positions to the hospitals and to more definitive care. So beyond ICP, there's a lot of really good trauma indications for this. One is like if you're trying to do a pupillary exam, sometimes that can be difficult in somebody that has a lot of periorbital edema, or they're just very difficult to get the exam that you need to get, and you just want to see if they have some pupillary response. And you don't want to like squish their eyeball too much in case they have a globe rupture. So, it's very nice. You can just basically put the ultrasound over the affected eye, have the other eye closed, and then open the good eye and shine a light into it. And then you'll be able to see that consensual pupillary response. There's another way to do this as well, and I can show you here. Oh, let me get this off. 1 second. I can't play this side right now because I can't turn this little guy off. Oh, didn't mean to do that. Where you're going to take your probe in the transverse plane. Let me see if I can get this to enter. Okay, there we go. And then you basically tilt the tail towards the head of the patient, and you're looking down through the eyeball, and then you're able to transect at that level of the lens right here. So then you're able to see that pupillary response to. I'll tell you, I tried this for a little while in one of our residents, and it was technically more difficult than just doing the transverse normal view, where you're just watching at the area of the ciliary bodies surrounding the lens. Okay, what are we seeing here?
A lens dislocation.
Yep, and this is great. You can definitely see lens dislocations with this, where it kind of, if it's a complete dislocation, you get that Cheerio that exists in the posterior chamber. These patients can have a variety of symptoms depending on if the lens is subluxed or if it's fully dislocated. They can obviously have decreased vision. They can sometimes actually see the lens in the corner of their vision because it's just partially dislocated or subluxed. And they might just be complaining of that kind of deep, boring ocular pain because they're actually cutting off they're having like intermittent angle closure. And it's usually due to trauma, but sometimes it can be a complication either right afterwards or much, much later of cataract surgery, or somebody that's had like retinal or vitreous surgery in the past. And then people that have like connective tissue disorders. So you can see here that there's like some variability to the degree of subluxation or dislocation. All right, what is this finding always concerning for?
Or globe rupture.
Correct. So with globe rupture, obviously this is always in the setting of trauma. And just on your physical exam, you're getting what we saw before, that distortion of the pupil. Sometimes you can actually see vitreous fluid leaking, and it's very painful for most patients. There's a lot of controversy on doing ultrasound for globe rupture. I think that if you are cognizant of those risks, and you're in a position where you need that information, that you can do it safely as long as you're very aware of the risks of increased vitreous loss. And the way to be really careful with that is some of the things you can do is obviously you're going to be using just a lot of gel for this exam. But if you use cold gel, that kind of tends to like pile up easier, so it doesn't, like when you warm the gel, it kind of gets liquidy and like oozes off of the person.
Yeah.
So if you use so if you use cold gel, you can stack it up higher and just make sure that you're not increasing any pressures. But when you think about like examining a patient, like a lot of times you'll be touching in that area as well. So if you're just very careful and you don't have access to other imaging, or it's time sensitive that you find this diagnosis, just to be aware of the potential risks and to tread very lightly, literally and figuratively. So what do we see? The first thing we'll see often is you'll see loss of the anterior chamber, and that makes sense because that's most contiguous with the outside world where the rupture is likely to have occurred. You'll get just this like very significant vitreous hemorrhage, and obviously as that eye juice is leaking out of the eye, you're going to have disruption of the normal architecture. So fairly easy if you do the exam to identify on ultrasound. There's some other eye trauma or traumatic processes that you can identify with your linear probe. What do you think we're looking at here in the CT scan?
Retrobulbar hematoma.
Yeah, you can actually sometimes see indicators of this on ultrasound as well, where if you kind of think about where you've got this really confined space behind the eye, that when blood accumulates there, you get this very rapid elevation of pressure, and that causes ischemia. It can cause irreversible necrosis of the optic nerve. You can get irreversible blindness pretty quickly. I did have one patient that was a delayed presentation for this, but he had already been blind in that eye, so that was helpful. That he did not lose vision from that incident, that he had already lost vision 25 years before. So, just when you get these patients that they were in a trauma, they've got pain, they've got inability to move their eye or limits to their ability to move their eye, and just that this can occasionally happen after surgery as well, but we typically see this in our trauma patients. And you can actually see like this kind of mix, this like more hypo echogenetic focus here of bleeding, but I think that this is a much better image where you can actually like see the blood that's accumulating in that retrobulbar space. Sometimes it'll actually distort the posterior anatomy of the eye, and will cause this guitar pick kind of shape for the posterior part of the eyeball. So those are just kind of things that you can look for when evaluating a patient for retrobulbar hemorrhage. And lastly, it's good for evaluating for intraocular foreign bodies, not so much for when things are sitting like right on top of the eye when you're looking at them directly. But if there is a foreign body, it's almost always going to be hyperechoic. If it's a metal, then you will have the reverberation artifact of it. It's pretty rare to see this, but sometimes you get patients where they do get something that actually goes into the actual chamber of the eye. And ultrasound's a good tool for identifying that. So really, it's those three major umbrellas of the painless vision loss when you're concerned about elevated intracranial pressure and after there's been a trauma that you would want to use your ocular ultrasound. And that's about it.